Assalamu alaikum, class 4th year morning and evening batch, group A, B and C. This is your course in charge Hirapsha, and I am going to present a new topic, asthma, today. Asthma is basically a clinical syndrome of lungs in which the chronic inflammation of the airways takes place and it involves the complex interaction between the many cells, example the eosinophils, mast cells, macrophages, neutrophils. These are the cells which are involved in the inflammation of the airways, and there are some inflammatory mediators, example the interleukins and the leukotrienes, that are responsible for causing the inflammation, and the obstruction also occurs sometimes partially or completely reversible after treatment, or it will resolve spontaneously. And the asthma has increased airway responsiveness, that is known as hyper-responsiveness of the airways, and the episodic asthma symptoms. So these are the things which are happening in asthma. And the two main reasons of asthma symptoms are which are responsible for asthma are the airway hyperresponsiveness as well as the bronchoconstriction. The causes of the asthma, or the causes that may trigger the asthma, may be the environmental factors or the genetic factors or some other factors. Environmental factors include the air pollutants or the pollen grains, and smoking can also trigger the asthma. Dust particles can aggravate this condition, and pets hair or chemicals. And the genetic factors involve the family history and certain genes. Other factors include the exercise or exertion, and the emotions such as anxiety, stress, hard laughter, or too much crying or very hard laughter can trigger the asthma episodes. The symptoms of asthma, as I have already discussed with you, that the hyperresponsiveness and the bronchoconstriction are the two main reasons for triggering the asthma. So it may result in the episodes of wheezing, coughing, and chest tightness and shortness of breath due to the bronchoconstriction, as the bronchioles are constrict. So the patient will unable to breathe properly, so the shortness of breath will occur due to this. Now comes to the classification of asthma. Medical professionals rank the asthma into 4 types from mild to severe. So these types basically determined by the frequency and severity of the asthma symptoms. So these 4 types are mild asthma, which has 2 types: mild intermittent and mild persistent asthma, and then moderate persistent asthma, and the severe persistent asthma. So these are the 4 types of the asthma, which I am going to discuss in my other slides. Number 1 is the mild intermittent asthma. This asthma, any of the following symptoms or may occur in this type of asthma if it is untreated. So the symptoms may include the difficulty in breathing, wheezing, chest tightness, and coughing. And these symptoms will occur or may occur on fewer than 2 days a week. And this is the frequency of the symptoms that it may occur, or they may occur fewer than 2 days a week, and they do not interfere. The symptoms may do not interfere with the normal activities of the person, and the night symptoms may occur, but on fewer than 2 days a month. And the lung function test or the spirometry, which include the force expiratory volume and the force vital capacity, and the peak expiratory flow rate, PEF, are normal in case of the mild intermittent asthma, when the person is not having the asthma attack. So the results of these tests are, the spirometry results are 80% or more of the expected value, or it may vary, and the peak expiratory flow rate varies less than 20% from morning to afternoon. Basically, the peak expiratory flow rate from 80% to 100% of the usual or normal peak flow reading indicates that the asthma is under good control. And if it is 50 to 79% of the usual or normal peak value, then it indicates the caution should be taken, and it may mean the respiratory airways are narrowing. And if this value is less than 50% of the usual or normal peak value, peak expiratory flow rate value, then it will indicate the medical emergency. Same for the spirometry or the lung function test. If the ratio between the force vital capacity and the force expiratory volume is greater than 80% or equal to 80%, then it will be normal. And in case of mild abnormality, it will be 70 to 79%, and in case of moderate, it will be 60 to 69%, and if it is less than 60%, then it will come into the severe category. Next is the mild persistent asthma. If the symptoms occur more than 2 days a week, but they do not occur every day, but it may occur more than 2 days a week, then it will be a mild persistent asthma. And these attacks may interfere with the daily activities of the person, and the nighttime symptoms may occur from 3 to 4 times a month. And the lung function test or spirometry are normal when the person is not having an asthma attack. And the result of these tests are 80% or more of the expected value, and it may vary a small amount, or the peak expiratory flow rate varies 20% to 30% from morning to afternoon. The third is the moderate persistent asthma. If the symptoms occurs daily and the person have to take the inhaled short acting asthma medications every day, in this case, and the symptoms may interfere with the daily activities of the person, and the night symptoms may also occur more than one time a week, but do not happen every day. And the lung function tests are abnormal, more than 60% to less than 80% of the expected value, or we can say that less than 80% to more than or equal to 60% of the expected value. And the peak expiratory flow rate varies from more than 30% from morning to afternoon. The fourth is the severe persistent asthma. In this case, the symptoms occur throughout each day and severely limit daily physical activities. They interfere with the physical activities severely, and the night symptoms occur often and sometimes every night, and the asthma attacks will occur. And the lung function tests are abnormal, 60% or less of the expected value. And the peak expiratory flow rate varies more than 30% from morning to afternoon. Basically, peak expiratory flow rate is the maximum speed of expiration. Here is the chart in which I have summarized these points. That the mild intermittent, mild persistent asthma, moderate persistent asthma, severe persistent asthma. These are the night symptoms frequency, and this is all about the symptoms of these types, and this is all about the lung function test. Now comes to the pathophysiology of asthma. As we have already discussed, it occurs due to the inflammation of the airways. When the antigen or the foreign particle comes, it will present it by the dendritic cells to the T lymphocytes, and then T lymphocytes will activate and release the interleukins, and these interleukins will be of further types: interleukin 4, interleukin 3, interferon alpha. These are the cytokines or the inflammatory mediators. They will release from these cells, and they will activate the other cells such as the mast cells and the IgE antibodies and the basophils and the eosinophils. And then these mediators of inflammation, they release the mediators of inflammation such as the histamine, prostaglandins, leukotrienes and enzymes, and they will cause the bronchial hyperresponsiveness and the bronchoconstriction or inflammation of the airways, and these all lead to the symptoms of asthma. Now come to the drug therapy. There are many classes of the drugs that are used to treat the asthma and the asthma exacerbations. Some of these are the bronchodilators, which include the beta-2 agonist and the anticholinergics, and the corticosteroids, leukotriene modifiers, methylxanthines and anticholinergics. The route of administration would be inhaled. These drugs can be taken through inhaled route, or they can also be taken orally or injected subcutaneously or intravenously. And the inhaled drugs comes in aerolized and powdered form, and the use of the aerolized forms with the help of the spacer or holding chamber facilitates the deposition of the drug in the airways rather than the pharynx. If the inhaler is taken with the help of the spacer or the holding chamber, then it will facilitate the deposition of the drug in the airways rather than the pharynx. Now come to the number one class, that is the beta-2 agonist or the bronchodilator. They cause the beta adrenergic receptors activation, and it will lead to the relaxation of the smooth muscles in the lungs and dilation and opening of the airways. So this is the mechanism of action of this class, and the beta-2 agonist preparations may be short-acting and it may be long-acting. Short-acting beta-2 agonist drugs are the albuterol, levalbuterol, and the pirbuterol, and the metoprolol. And the long-acting beta-2 agonist drugs are the salmeterol, formoterol, arformoterol, bambuterol, etc. Next is the corticosteroids. Corticosteroids are of two types. Number one, systemic corticosteroids. Number two is inhaled corticosteroids. Systemic corticosteroids are the prednisone, prednisolone, methylprednisolone, flucortolone, and the triamcinolone. And the inhaled steroids include the budesonide, beclometasone, dipropionate, flunisolide, and the fluticasone. Mechanism of action of these corticosteroids is that these drugs bind to the glucocorticoid receptor on the cytoplasm of the cells, and they activate these receptors which regulate the transcription of the target genes. And then corticosteroids reduce the inflammation via inhibition of the transcription and release of the inflammatory genes. They inhibit the transcription of the inflammatory genes, and they also stop the release of these inflammatory genes. And they increase the transcription of the anti-inflammatory genes that produces the protein that participate in or suppress the inflammatory process. So these two mechanisms help to reduce the inflammation via corticosteroids. Third is the leukotriene modifiers. The leukotriene modifiers or the leukotrienes are the most important mediators in allergic asthma. Leukotrienes are responsible for triggering the asthma symptoms, and they are released when the allergen comes in contact to the mast cells or eosinophils and basophils. When the mast cells, eosinophils or basophils activate by the presenting allergen or antigen, then the leukotrienes are released. So the leukotriene modifier drugs are given to stop the release or to antagonize the receptor of the leukotriene, so their effect can not take place, and the inflammation may reduce by this mechanism. So the leukotriene receptor antagonist drugs are the montelukast, zeferlukast, xylutone, and the mechanism of action include the anti-leukotriene inhibit the synthesis of the leukotrienes, or they may interact with the receptors of the leukotriene. So the xylutone is a leukotriene modifier which blocks the effect of the 5-lipoxygenase which is responsible for the synthesis of the leukotriene, and ultimately blocks the leukotriene production. This enzyme is responsible for the production of the leukotriene. If we block this enzyme through the xylutone, then the leukotriene production will not take place. Next is the methylxanthines or theophylline compounds. These are the non-selective inhibitors of cyclic nucleotide phosphodiesterase such as theophylline, which have been used in the treatment of the bronchial asthma. It is the it has the moderate bronchodilatory effect, and the phosphodiesterase inhibitors are responsible to reduce the airway inflammation, and they are effective against the early and the late phase allergic responses. The mechanism by which the methylxanthines exert the anti-inflammatory effect involves the adenosine receptor antagonism, and through elevation of intracellular cyclic AMP or the adenosine monophosphate concentrations. The direct relaxin effect on the smooth muscle will occur due to the increased cyclic AMP production, as well as inhibition of mediator release from the inflammatory cells, so that the inflammatory mediators cannot be released from the inflammatory cells due to the increased production or increased levels of the cyclic AMP. So this is the mechanism by which the methylxanthines or the theophylline compounds exert the anti-inflammatory effect. Next is the anticholinergic. They antagonize the muscarinic receptors such as the short-acting ipratropium bromide. It non-selectively inhibit the effect of the acetylcholine on muscarinic receptors, and it play a vital role in the treatment of the asthma. Ipratropium bromide is administered through inhalation route, and it is also used as needed medication in case of intolerance to beta agonist. Now comes to the case study, and here is a woman, 30 years old patient who came to the allergic clinic or outpatient clinic for allergy and respiratory problem, and she is presented with breathlessness and cough, and she had a history of allergic rhinitis. The subjective findings include the history of present illness, breathlessness and cough, and her peak expiratory flow rate varies between 150 to 400. The medical history include the mild persistent asthma, and allergic rhinitis was diagnosed since the age of 6 years, and by the age of the 12, asthma symptoms almost disappeared except some of the cough and wheezing when she got flu. So in the last 2 years, this patient is under the medication of the inhaled salbutamol 100 mcg microgram 3 times a day, and budesonide 250 mg inhaler twice a day. Her peak flow rate had remained constant around 400 prior the last 2 months, and she was not regularly using the antihistamines and nasal corticosteroids for rhinitis symptoms. The objective findings include that she was speaking in complete sentences with a respiratory rate of 50 breath per minute, and her blood pressure is 120 by 80 mm of Hg, and oxygen saturation is 98%. Her weight is 95 kg and height is 166 centimeter. The oscillation of the chest shows the bilateral expiratory polyphonic wheeze with vascular breath sounds. These are the breath sounds, and there were no other abnormal findings on examination. Temperature was 95 degree Fahrenheit, and the peak flow rate in clinic was 350 I per minute, and on room air. The chest X-ray was normal and CBC was normal.